much less severe spectrum of disease here than anaphylaxis. This cases came up a couple times recently in lower acuity areas, but there were some questions about management, so decided to go with that as my topic. So I have a case for you, and here's your case. Doc, my throat is killing me, I can't swallow. Okay? And it could be either one of these presentations or everything else you've seen in between. So we're going to talk about what to do about this for sore throat in the 18 or older crowd. I'm Mike Lanigan, one of the core faculty for the few people I haven't interacted with yet. Okay, so obviously when you're thinking of causes, you've read the vital signs, you're walking to see the patient, and obviously you're thinking infection high on your mind, right? You're like, another URI probably, but maybe they have strep, so as you're walking over there, you think of other things too, right? Don't forget mononucleosis. It can present a lot like bacterial strep infection, lymph nodes, exudative tonsils. Usually the prodrome and the course of the disease is longer. It can be up to weeks. And on physical exam, they may have, anybody? Splenomegaly, yes. And I absolutely 100% felt splenomegaly in a case recently. Young lady, about 23. So I told her she had mono. Her first test was negative. That's the other thing about mono, caused by Epstein-Barr. You have to make antibodies to it for the test to be positive, the heterophile antibody test. And they may not turn positive for weeks, so you usually have to invite them back to have a second test. But don't be sloppy, okay? Because there's other things that can cause sore throat, right? The childhood diseases, we're not going to see that much of that, but just know chickenpox, measles, things like that can cause it. You may see something that is an exudative tonsils, but you see a white exudate, maybe thrush, CMV, obviously you're going to think about immunocompromised cases there. Reflux, they tell you, Doc, my throat's killing me, it burns at night, often happens after I eat, you might be dealing with that, okay? And then this other stuff that doesn't seem as medically crazy, but think about it, irritants like cigarette smoking, your allergies, somebody has seasonal allergies, and environmental exposures, okay? So, you younger guys, you'll hear this, talk about this a lot over the 4 years. Take a good history. The history will give you the answer a lot of times. If you do, you may come up with one of these causes. And then, of course, there's tumor. They tell you, Doc, I've had a sore throat for 2 months. I smoke 3 packs a day. I want to think about doing a little bit more in your workup, okay? All right, so you've seen the patient. You've decided, okay, I really think this is an infection. What am I going to do? Okay, what are your options? Okay, not necessarily here, but at a lot of places they have a rapid strep test. Okay, how rapid it is depends on where you are. We do offer this at the urgent care in Bay Ridge. It takes about 90 minutes. Some times it takes longer. That doesn't seem really rapid to me, but it's there for you, right? Then you have the gold standard throat culture, right? Get in there, get a nice swab. You have an adult, so you're not going to have a kid pulling away, hopefully. That's probably still your gold standard, right? Or you could do no tests, right? Okay, you have your H&P, and you have this thing called the Centaur score. Can you apply that to adults? Yeah, you can, okay? mdcalc.com, the answer to everything for all your clinical questions, right? It's right there. Basically, you get a point for being middle age, if you will, less than 44 but greater than 15. Older people, not so much. Kids are their own category, of course. Sorry. You get a point for having tonsils swollen or exudative, anterior cervical lymph nodes, fever, and then a negative point if you have a cough. So you can put all that together and you'll have a percentage of whether you have strep throat or not. Okay, so you can apply that if you want, but generally just using your H&P skills. So now what can we do for them? Okay, first option, supportive care. You can say, you know what, you're going to be fine, it's just a sore throat, go home, etc. You can have them gargle like my mom used to do, right? Whip in a little half a teaspoon of salt with 8 hours of sort of lukewarm water, gargle with that. Oh, this is definitely the trick. That's what she's telling me. You can give non-steroidals, of course, Shalatornil and ED, Motrin or Aleve at home, Tylenol, etc. You can give antibiotics. You know that, of course, right? That's what many of our patients want you to say, okay? Or you can give steroids, or you may give both together. Who knows? But we're going to kind of focus on these last two initially, right? So that's basically the options. Okay, so there's your patient. stressed, he has to sing next week, saying, "Doc, you gotta help me." You know, and what do patients want? They know they're getting a bill, right? They're like, "Oh my God, so you gotta do something for me." They usually want a test, but not always. If you can tell them what the diagnosis is with, you know, fair certainty, they may live with that, but basically, they want you to make them feel better, right? That's really the only reason somebody with a sore throat would come to ED, right? They're really hurting, right? Okay, so what are the issues? Let's talk about two things. Testing. So, about these couple tests I brought up earlier. They're pretty accurate, okay? Rapid strep used to be not very sensitive back when I was training. It's up to, in most studies, in the 80s now, which is it's pretty good, right? And sensitivity varies a little. I've seen some studies where it's in the 60s, some as high in the 90s. So I think that's pretty decent. But it costs money, right? You may be able to walk into some clinics and get it for, you know, 2 digits, $30, something like that. But if you go start doing urgent care and EDs, then you're starting to get up in the hundreds, okay? So it costs. And a lot of people feel like you have to follow it with a culture, okay? That's maybe a little bit old school thinking, but I still see people do that. Because they're like, well, I don't know, let's get the definitive test. All right, as I said, you can also cut straight to the culture. Good accuracy, at least as akin to rapid strep, but it costs. Now you're talking in the hundreds for sure, okay? 100 or greater. And there's a delay to diagnosis. How, you know, you go to the doctor, you want to feel better, they do a test, and you're like, come back in 2 days, right? Or call the lab, or you can't call because HIPAA or whatever. So there's that sort of delay in getting to know what you have. As far as complications, you know, what could happen if you get strep? Well, we're starting to learn not that much in developed countries. Post-streptococcal glomerulonephritis, which is what PSGN is, treating strep will not have any effect on that. We learned that a long time ago. It's a concerning complication. There's nothing we can do about it. The other one that was concerned throughout the years, throughout the 20th century, was rheumatic fever and subsequent rheumatic heart disease. That is not an issue really in developed countries anymore. When I was training back with Dr. G many years ago, I remember 9 days was kind of the window where if you treat him there, much less risk of this. It's really not that prevalent now, so it's not really an issue. So there's a couple issues to think about. And furthermore, penicillin is cheap. Penicillin is the treatment. It's still the treatment. It costs about $4, one of those $4 drugs, right? You can get at Target, etc., right? And you even have the option of giving an injection and being done with it by penicillin LA. Treatment with both is pretty good. I mean, for me, I have trouble even taking pills in the morning. To have to take 2 to 3 times a day for at least 7 days, 10 days, that's difficult. So if you can be one and done, that's good. And Decadron, you can treat with a single dose and get good results. So do you see what I'm talking about? Okay. So where do we get our answers? A lot of places, but this generation and myself, everybody, we go to phone, right, to get a lot of answers. Everybody knows this guy, right? Swami Nathan is the program director at Bellevue. And I took his teaching course, him and the other guys and ladies last fall. Really great course. They've apparently had a little bit of a disillusion of what they are doing, but I think they're emerging in a couple of groups. If you're going to go into academic, if you're further along in your training, you're thinking about going to academic, I would highly recommend you take the course from one of these guys. It was really good. So he does a site called Rebel EM with a couple other guys. They review a few papers each month. And back in January 2015, they looked at this issue. And Swami was the one who wrote the review. And he has, and this came up on my phone 4 or 5 months ago, and I did what I usually do. I forwarded to my email account to read sometimes 6 months to a year from now. But I actually did read this one right away. I really did. And he has some great points right away. He brings up, first of all, the whole rheumatic fever heart disease argument that it's not really relevant anymore. He cites a couple papers where there's a high number needed to treat for suppurative complications. Particularly, he cited a couple papers in the mid-2000s where the number needed to treat for peritonsillar abscess, PTA. One paper cited about in the high 20s, another one was way up in the 200s. So it's a fair number of people, right? And about 1 in 10 people will get antibiotic-related diarrhea. Not necessarily C. diff, but diarrhea nonetheless. And then you have the allergic reaction. Now 0.24, that's not very high, but when you start thinking about your career and you see a lot of patients, Sure enough, I saw somebody going to anaphylaxis from Zosyn fairly recently. Fortunately, she was right there. We were able to treat her right away. She had a good outcome. But it was pretty scary to watch right in front of you. You're like, gosh, she'd have anaphylaxis from something we gave her. Think about if you give somebody penicillin. A lot of people don't know if they're allergic to penicillin. They haven't had it for a long time. They don't remember what their mom told them when they were younger. Okay? So you may give them penicillin and they may have that reaction outside the hospital. I would recommend, if you're going to give somebody penicillin, if you're going to treat this, I would treat with penicillin and I would watch them in the ED for a while. Make sure they don't have a reaction. But there's always that risk, okay? It's, again, not that high, but if you think about the hundreds of patients you treat, you're probably going to see somebody eventually. All right, so then he goes on and brings up some other issues, and he's an advocate for treating with steroids only, okay? And he cited a paper by Hayward in 2012 where to reduce symptomatology with steroid, the number needed to treat is 4. Wow, that's great, right? That's not very many people at all. So I did what I don't always do, because I was preparing this talk for you guys, and I was going to wow you with this fact. I read the reference article. And guess what I found? In the Hayward paper, both groups got antibiotics on top of that. So basically it was a paper about one getting antibiotics alone and one getting antibiotics with steroids, which if you read what he writes in the paragraph, unless I grossly misunderstood something, is not what he's trying to argue for. And I was like, now what? You know, I don't know if I was mad as Hulk here, but I was a little mystified. I'm like, this Swami, you know, he's supposed to get something a little better than this. So I was a little disappointed, and I had to scramble a little bit, and yesterday, and I'm like, I got to really get this together. What am I going to tell these guys? How am I going to get them to believe this guy right here? They just happened. So I did my own literature review, and quite frankly, it wasn't very fulfilling. A lot of the Cochrane reviews are about kids, about people who got antibiotics. Also, there weren't a lot of good meta-analysis studies out there. I did find one, there may be others, but I did find this one paper that I thought sort of approximated what we're dealing with today. It was from JAMA just this year, which is good. And it was 565 patients in a primary care setting in England. Now, is that exactly what we're dealing with? I'll talk about that at the end. No, not exactly. But if you think about it, we do a decent amount of primary care here, particularly in the pod or in the fast track, right? And then I liked this because it was a placebo-controlled double-blind study. And everybody who went through the study got treatment. They either got a sugar pill or they got 10 milligrams of Dex. Okay? And it was pretty well randomized. I looked at the demographics and everything. And the treating physician had the option to give either no antibiotics or delayed antibiotic at 48 hours. So you're like, well, there's the antibiotics again. Well, no, because what they did was they looked at patient, all of them, at 24 and 48 hours to see what their symptoms were. So the antibiotics really didn't play a role. And they actually did study those people worked out later, and there was no difference in the two groups in the people who got antibiotics and didn't. And what they found was, and again, this is subjective, it's not objective, it's not like you can't make death and good neurologic outcome or anything like that, but they asked the patients, and there was an increased likelihood of symptom relief at 48 hours, not at 24, but at 48, and they looked at both. Again, what are the bad parts of this? It's not an ED, it may not be our patient population, I don't know who's in South and West England that they specifically looked at, but I thought it was a pretty good study as far as what I was really looking to answer, which is, should we give steroids versus nothing? So, summing this all up, this is my advice. Testing, I didn't really talk about it, or maybe I did, the prices, yes I did. Strep test is expensive, right? Especially if you get into our setting, urgent care. ED cultures are expensive. I really don't think you learn much from it. So I would tell you, abandon testing. Maybe in a rare instance, somebody needs to know, somebody insists they need to know. You're not getting any epidemiologic data from it, right? We know what it's going to be. It's going to be base strep, okay? We're not tracking bird flu here, or swine flu, or anything like that, so you don't really need to know that. You're not making a diagnosis. You know what it is, right? Okay, it's not going to be E. coli, right? So I would say give your treatment based on the H&P, and again, go back to my slide from about the third one. Think about those other things. Make sure you don't miss something, being sloppy, and not asking the right questions. And then I would tell the patient this. I would say, look, in adults, the percentage of strep is much lower. It's about 5 to 15%. It's most likely a virus. It's going to get better on its own with supportive care. If it is strep, again, about 5 to 15%, depending on what study you read, it will likely get better on its own with little risk for complications. Okay? And I'm finding more and more patients are a little more savvy. They're really a little more willing to listen to this kind of information. Okay, I could give you antibiotics. What most literature shows is that you may, not necessarily, may get an improvement within about 16 hours. If you do, but you have the risk for allergy and you're at risk for GI illness. If I give you steroids, there's a pretty good chance that in 48 hours you're going to feel better regardless of the cause. There are certain people you're not going to give steroids to. There's nothing written in the literature that says who those people are. I'm going to leave it to you guys to use your common sense. You're not going to give somebody steroids who just had a course of chemo yesterday, right? So this is the algorithm that I'm suggesting you making. You're going to hear those words all throughout your training: shared decision making, return precautions. I think this is a good patient to do shared decision making with. Go over those issues with them. I would give antibiotics very selectively, if at all. I went to a conference a couple years ago where the big wigs were there, Hoffman and everybody like that, and everybody agreed testing really shouldn't be done. If you're going to treat, just treat. I would opt possibly to treat with dexamethasone. Depending on what you read, 10 to 12 milligrams, POIM, I don't think it really makes a difference. And then the staples should be non-steroidals, resting, and hydration. I tell patients, make the straw your best friend. I know you say you don't want to drink, make yourself drink, okay? Keep yourself well hydrated, you're going to get better sooner. Give them good return precautions. I give all this advice with one anecdotal story. Close to my heart. That's my oldest son, David. He's 21 years old. And this September, he said, "Dad, my throat's a little sore." So I looked in there. Wasn't very impressive at all. He didn't have a fever or anything like that. And then a couple days later, he said, "It's still bothering me." I said, "Okay, I'm going to call in a script for some steroids for you. You should feel better in a couple days. Drink a lot of fluids, etc." So we did what we normally do at home is we passed like shifts in the night for about 5 days. I was working odd shifts, he was working his job, etc. And he got to me about a week later. He said, "Dad, my throat is still really killing me." I said, "Okay, let me take a look." And bang! That's what we saw. What is that? Everybody know? That's peritonsillar abscess. He had a peritonsillar abscess. I was supposed to go away that night. I'm like, really? Come on. You never stop parenting. So I called a couple urgent care centers. Nobody wants to touch this. I said, "You got somebody there who can just drain this?" We even have a PM Pediatrics in my town. And nobody wanted any part of it. So, sum it all up, what followed was a trip to the local ER. Fortunately, St. Barnabas, which is our local hospital, has a PTR. They weren't busy. I called ahead. Came in there. The doc actually grew up on the street we live on. So we got into the PTD. He said, "I want to do labs and a CAT scan." It's really hard for me. I want to intervene, but I've made a vow not to do that. Okay, what do you guys want to do? And he said, "I have ENT. It's Newark, Beth Israel. They'll come if there's something there." I said, "Okay, fine." Uneventful labs, IV, CAT scan, huge abscess. You can see it on the CAT scan. The resident came in. She was very nice. Seemed pretty good. She did what we normally do. Got the needle, cut it off, and then attempted to drain poor old Dave's abscess. And Dave was having no part of this. That sounds a little bit of a chicken, but we went through about a half hour of this, trying to pull. And I don't know if Crystal's here, but we did this with another patient at UHB not too long ago. Just could not do it. So she goes and talks to her attending, and she comes back and says, "My attending wants to take your son to the operating room." And I'm like, "Well, you're going to have to put him out, right, to drain it?" She said, "Yeah." I said, "You got to be kidding me." Now I'm hours into this. Again, I was supposed to go gamble in Connecticut. So good news is he went to the OR. He was out in about 45 minutes. He was goofy when he woke up, but we got to go home that night. Everybody was great. And you have to follow up with the ENT. He healed up real well. I looked at it myself a couple times. And I now have a $2,000 anesthesia bill that I'm trying to get because they don't take my insurance. So all this happened to me. Yes. Who's had high bills here? My last son was in the NICU, $125,000. 17 days in the NICU. So costs are real, okay? You guys know the population we serve here. Costs are real. Those are real things to keep in mind. You know, I know everybody wants to do what's right for the patient and all that, but we've got to think about these things sometimes. I know I was definitely thinking. So there's my story. I'm still sticking to my guns here. And in conclusion, I would say Keep it simple. I would defer, not do testing. I would do shared decision making with the patient. The other thing I learned, read your phone references, okay? I think everything out there you can trust. I'm definitely going to question Swami about this because maybe I misunderstood what he said, that I didn't think he was exactly saying what he was trying to show in his article. So read your phone references, make sure they are what they are, and caca happens, okay? Like happened to my son. Things aren't always going to work out the way you want, but if the numbers support you, I would still say proceed as you know is the right way. So peace out, and I think it was my favorite thing, you can't fix crazy, I'll give you this document.